presentation, and I invite Dr. Ram Agarwal sir to be a chairperson of this session. Dr. Mohit, you can start.
Good morning, everyone. Good morning, Chairperson. We have been listening on the use of plate with rail on femur. We have been listening on nail with Elizorovs. So I'll be talking on use of plate with LRS on segmental defects of tibia. So if we see gap non-union of tibia, it's a major challenge. Why? Because we have a bone loss. The bone loss is not just because of the trauma, but it's also because of the multiple surgeries which this patient undergoes. And because of these multiple surgeries, the innate environment of the area of the surgery is not the same what is there at the time of trauma. So it's for the surgeon, it's actually time consuming and technically difficult. And for a patient, it's physically demanding and also psychologically demanding. So what are the problems we have to tackle? We have to tackle the union. We have to tackle the gap of the bone, and we have to maintain the limb length and alignment. So for this, the classification of gap non-union of tibia, where Dr. Pele has divided into A and B, this has to be remembered. So if we, okay. So I'll be talking on type B fractures where the gap is more than 1 centimeter, and that is being divided into B1, B2, B3, that everybody knows about it, where B2 and B3 corresponds to the shortening with no bone gap or a bone gap, but B1 there is no shortening with the fibular length is maintained. So this is the classification picture. How do we manage these cases? First of all, we have to first manage the infection. We have to cover these areas with soft tissues. Then we start managing this bone gap, and then we start achieving union. So this is the dictum what we have to follow. First, manage infection, cover this with a proper soft tissue, then you manage the bone gap, and then achieve union. So first, starting with the management of infection. For management of infection, the debridement is the key. We have to remove all the dead tissue, remove all the sinuses, give him optimal antibiotics according to the culture sensitivity, and then we start with the management of bone gap. So bone gap has been managed by different techniques, like muscular technique, where you create an environment for the bone graft to be put, and then the graft takes up in the environment. But if we see, you require a lot of bone graft to be used there. So other procedure is Huntington procedure, where the ipsilateral fibula is being transferred to the tibia, and we wait for it to tibialize. Then comes the bone transport, what we have been talking about since last 2 days. So bone transport is nothing but a bone regeneration, which is being regenerated with the help of controlled distraction. This controlled distraction can be brought about by Elizarov and ring fixator and limb reconstruction system. So it has two phases. There is a phase of bone regeneration, and there is a phase of consolidation. So the phase of regeneration is nothing but the amount of time which the bone segment, when we make this bone segment to move from one part to another, it takes that time to reach the contractile bone. And the phase of consolidation is the time for which they regenerate, takes strength to bear these shear and torsion stresses. So if we see the phase of regeneration and phase of consolidation, it is most of the times we use external fixators like LRS and Elizarov, and these times have been covered by the LRS and Elizarovs. So for a centimeter of the bone to be produced, we actually need approximately 30 days for this regenerate, so that it can take shear and torsional stresses. So this is nothing but the external fixator index. So we'll be other things which we face with this use of external fixator are the complication with the prolonged use, which are pin tract infections, joint stiffness, malunion, and patient compliance. So if we have a palate type B2 and B3 fracture, I think the answer is only external fixator. We can't go for a combined system of using a plate or a nail. Plate. Nail, you can always use it, but plate, you can't use it because you're fixing it and then the length can't be achieved. But if you have a B1 fracture where the length is there, the length is not an issue, then we can go with all these combination of nail with LRS, nail with Elizarov, plate with LRS, all these things. So So what are the advantages of this combined use? The advantages are it maintains the alignment, it prevents malunion, non-union, it decreases the external fixator time, it increases the compliance of the patient, and also it helps to protect this regenerated bone and attains union for a long time. So what is important is first we have to eradicate infection and we have to provide adequate soft tissue coverage. Then we go on to fill this bone gap. So the methodology involves, if you have this type B1 fracture where there's a bone gap with the fibula intact or the fibula length is maintained and you have normal CRP and with adequate soft tissue coverage, you start with first plating this whole tibia with a long plate and fix this, the proximal and the distal ends with the help of screws. And then you apply LRS onto the other side of the bone, do a corticotomy, try to transport this bone segment down at the control rate, and once this bone segment reaches the other part, just fill in with this bone segment with 1 or 2 screws and take out the external fixator. Now you wait, this was the regenerated phase for which the external fixator was applied, and now you wait for this regenerate to consolidate. And so these are the clinical cases, few of my cases. This is one case with a 21 years male. He had a bone gap of 4.5 centimeter and he had good adequate, there was no sign of infection at that time, and there was good soft tissue coverage over the tibia. This patient was applied a long plate on the lateral side of the tibia, fixed the proximal side, fixed with the distal segment, and then the LRS was applied onto the medial side. Now, corticotomy was done and the middle fragment was moved in a controlled fashion, and when it reached the distal part, just 1 or 2 screws were applied onto the middle fragment, and we waited it to consolidate and see how the good union was achieved because of the solid fixation. This was a clinical photograph. So if I just focus on the number of days which the fixator was applied, so it was just 10.88. The external fixator index was 10.88 days, and total time for which the fixator was applied was for 49 days for 4.5 centimeter of the bone or the bone gap. So this is the advantage of using a LRS along with the plate, and we have achieved excellent bone and Asami results, bone and functional results of Asami. Another case is 55 years old male. He was a viral positive case. He actually died because of respiratory complications. Later on, he had a bone gap in the distal part of the tibia. We had applied a medial side plate. We had applied a LRS on the opposite side, on the lateral side. We transmitted this bone down to the distal part and fixed that segment with the help of screws and waited for consolidation. See how the consolidation formed here, because he was not compliant enough to come to the hospital. So when he had come to the hospital and we had removed the external fixator, the regenerator was already consolidated. So the time which he took for the removal of the external fixator was 168 days for 3.5 centimeter bone. So just because of his compliance that he was not compliant enough to reach the hospital. Another case, 37 years male, he had a bone gap in the distal part of tibia, gap non-union, and he had a history of RTA 2.5 years back. We applied the same principle. We applied a lateral side distal plate, and we created a bone gap in the distal fragment, and corticotomized the middle, did a corticotomy in the middle segment and transported the bone down. And once this bone had reached the distal part, we had applied 1 or 2 screws in the distal part and waited for the regenerate to consolidate. So this is his clinical photograph, and see, for the 4.5 centimeter of bone to be produced, the external fixator time was just 56 days. And the fixator index was 12.44 days per centimeter. Another case, 28 years male, same the fibula length maintained, bone gap was there for around 5 to 6 centimeters. Same way the plate was applied, LRS applied, corticotomy was done, the bone was transported down, and here we had done a bone grafting because we saw some bone gap present at the fracture site. This is a clinical photograph, and these are these outcomes. So a total of more than 15 cases has been done. We have good amount of bone and functional results present, and good MSC scoring. So we had few complications like pin-tendon infection, ankle stiffness also, but ankle stiffness was mostly present in the cases where we had done the we had applied a distal plate there. So to conclude, Composite use of monorail fixator and locking plate decreases the fixator time and associated complications. The choice should be restricted to only pellets type B1 group, not B2 and B3. We can attain a good anatomical and functional result with high emotional acceptance. Thank you for your patient listening. Thank you.
Dr. Mohit. Dr. Mohit.
Yes, sir.
So it's a nice procedure, but in some of cases I found that the tibia bone who is being translated, it is shifted, angulation took place.
Yes, sir.
In two of your cases.
Yes, sir.
So how you manage that?
So, sir, when we were applying screws into when we were taking out the external fixator, so we had put a cortical screw to pull the fragment towards the plate itself. So that had maintained the alignment. I'll show you in one of my cases, sir.
Yeah, you so.
Can you just keep it?
Back kar diya.
Yeah, if you see this case, this proximal segment is actually moving towards the LRS. And in the further X-ray also, it started moving further. One second. This. So proximal segment is moving towards the fixator. See, this is the angulation which was produced here. So when we had taken out the external fixator, at that time we had applied one screw, the cortical screw, into this fragment, and it has pulled the fragment towards the plate. So alignment was maintained this way at the time of removal of external fixator.
Second problem, usually these gap non-unions are infected.
Yes, sir.
Usually.
Yes, sir.
So do we have any problem with the infection?
So, one case had an infection which was managed with local debridement, but later on we had to remove the plate, but the regenerated consolidated well. So that time we had no problem to remove the plate. Only one case. Rest of the cases I didn't have any problem because initially we had taken into consideration that there was no infection. It was a quiescent kind of gap non-union with normal CRP levels and good soft tissue coverage. So anytime when we have done the debridement in the first stage, we do an adequate debridement so that we don't leave anything inside.
At the site of the non-union, sometimes one has to open that because the bone is sclerosed.
Yes, sir.
In your cases, you have opened.
We have done bone grafting, sir, in few of my cases. Half of my cases we have done mostly, we have done bone grafting at that time. Initially, we saw that when we were taking out the external fixator, the region was pulling the bone up. So that time the bone gap was created and we couldn't bring that down. So that was filled with bone graft. So later on we realized that first fix it with a plate and then take out the LRS. Don't take out the LRS initially.
Yeah.
First fix it with a plate, get a stable fixture, then remove the LRS.
Thank you.
Yes.
For that?
Actually, he didn't have a good soft tissue condition on the lateral side. That was a case where he was a viral positive case. We had applied a plate on the medial side. So that is why we applied.
So the lateral soft tissue wasn't very good.
Yes.
Okay.
Thank you very much. So next speaker, Dr. Lakshmi Narayan has come.
नहीं सर LRS सेशन है
वही टिंगरा की फ्लाइट थी ना तो ही हैड टू गो LRS सेशन स्टार्ट
वी हैव डॉक्टर
मनीष प्रसाद हाँ कल
So I invite Dr. Manish Prasad on his talk on LRS, how to get it right.
Respected Chairperson, sir, and good morning, everybody in the audience. So thank you for this opportunity. The topic on LRS was supposed to be introduced by me, but anyways, due to paucity of time and some other constraints, Dr. Dhingra had to present it first. So my topic is LRS in the management of segmental bone defects, how to get it right. I'll just introduce the topic. So we all know that a critical segmental bone defect is a void that will not fill without any intervention. That's the most articulate way of describing it. And in adult patients, a critical bone defect generally has a circumferential loss of more than 50% or a length of more than 2 centimeters. Without a proper intervention, it won't heal. So this classification already Dr. Dhingra has described. We all know that high energy trauma and debridement procedures, some tumor resections, and in cases of congenital anomalies, we end up having segmental skeletal defects. More or less, limb length discrepancy with mild angulation and deformity, fractures with bone loss, and segmental fractures are primary indications of LRS. Now, why LRS? It is a monolateral fixator that works on Ilezerov principles of destruction histogenesis. It is comparatively easier as compared to a ring fixator. The stability is almost comparable. We may call it more forgiving, and it definitely has a shorter learning curve because most of us, when we start our careers, we start with an AO fixator. So there are differences which we all understand. The instrumentation part and the components part, we all know that there are rails, there are buses or clamps, the differences between the central and the end clamps. There are swivel clamps which allow angulations. There are ball and socket clamps. And there are dyna ring, there is a dyna ring which allows compression, controlled compression, and etc. Then there is the most important thing is the CD unit, which differentiates it along with other components from a standard AO fixator. Now, I'll be trying to get some perspective into it, how to get the thing right. So the first and foremost thing is that we definitely should have a good knowledge of each and every aspect of the instrumentation, the components, and it's good to have a CM support like we should have a proper placement of the CM and an operator who's doing the thing right. We should be aware of the contraindications. It's not that you have a case and you get inside and try doing an LRS. So what are the relative contraindications? Severe angulations and deformities that you can use a ring fixator better, wherein you can use a ring fixator better. Severe osteoporosis because the pins may not hold as well. And definitely patients who do not cooperate, it goes true with any other implant in orthopedics. There should be minimal soft tissue injury in a case where, like in the previous presentation also we saw that this was discussed. In a case where there is the soft tissue injury is more, we should try and go in for a ring fixator. Mandatory pre-drilling with appropriate size bit, it goes through for any external fixator. Use of templates for perfect, that is parallel placement of pins according to the bone axis, the long axis of the bone. Use of coolant during drilling to ensure minimal thermal injury. I just want to recall my a few days of training under Dr. Milind Chaudhary, sir, when I had gone to his center, when I saw him applying any external fixator. The assistant was constantly having a drip in a syringe and pouring it over the drill area till the time the pin was perfectly placed. So use of appropriate sized tapered Shan's pins, which is a new item actually in the inventory. It has not been a very long time since it had been introduced, with a bicortical purchase. And it should not be backed up even partially because it will lead to the entire pin loosening. HA-coated pins would be better because it reduces the chances of infection and it has got a higher pull-out strength. To start with, the proximal most and the distal most pins should be applied initially. It again is the same as the principle of a normal external fixator. Minimal 3 pins should be applied. We should try to have minimum 3 pins in each major fragment. The rail must run parallel to the long axis of the bone, goes without saying. Because it's a monolateral fixator, that is the only way we are going to align the bone along with the fixator. The alignment of fragments should be ensured as close to perfect as possible, and but we have to also remember one thing, that while doing the same, we should not be injuring too much of the soft tissues also. Use of T-clamps for the purchase of small metaphyseal fragments, and small metaphyseal fragment, as we know, is a relative contraindication for using an LRS. Use of swivel clamps for allowing angulation to the pins. Suppose we are putting it, trying to apply the LRS in the proximal femur or the distal femur or in the proximal tibia. This may come handy. We should be trying to ensure absolute mechanical stability of the fixator, and if needed, the transfixation across the joint should be done. These days, modular fixators like the alpha fixators are available, wherein there is a one unit which you can apply right from the proximal femur till the distal tibia with an arc with hinges in between at the knee. And you can use a part of it also, or a complete fixator in case you have an injury, something like a floating knee injury or a comminuted femur and a tibia injury. We can use these kind of modular fixators. Use of Dynaclamp for dynamization at the end of the docking. It's very important to have a perioperative counseling session related to pin tract care and rate and rhythm of distraction, because they are directly and indirectly related to the stability and the efficacy of the fixator. It's very important to maintain an early range of motion wherever it is possible. Of course, when you are transfixing a joint in the presence of a very small metaphyseal fragment, it may not be practical, but wherever we are applying an LRS, thinking of it as a definitive fixation, we should try and apply it as stable as possible so that an early range of motion and functional capabilities of the patient are ensured. And yes, early weight bearing to ensure that the better remodeling of the bone takes place subsequently. So just a few slides on pictures of some basic steps. So the drill guide should be located in the center of the diaphysis, and it should be perpendicular to the shaft. And mind you, these when we do this, we should be doing it over templates. We should not be trying to directly apply the pins under the final clamps. The other good tip will be that an all for soft tissue spreader is helpful in locating the shaft axis, which is available with the implant and the instrumentation set of a standard LRS. So this will maintain the AP as well as the sagittal orientation of the rail of the LRS. After we have applied the proximal most pin, the distal most pin should be applied. This helps in alignment as well as maintaining the length of the bone, whatever we want. Once the most proximal and the most distal pins have been applied, then through the template only, rest of the shank screws should be applied, and then removal of the template and the final buses should be placed and the nuts should be tightened. So just a few tips on especially the transport after proximal femoral corticotomy. We should try and put at least 3 pins, which I have already mentioned. They should be spread widely across the length of the clamp. There are 5 holes, so every alternate hole should be used. The 2 pins that straddle the proposed osteotomy site should be around 3 centimeters apart. And of course, the widest diameter of the bone for the best purchase of the pin should be used. We should take time and follow these steps. In addition, it's not just the application of the LRS which is important, but we should also understand and make the patient also understand that what are the factors that will lead to a good bone healing after application of the LRS. So mechanical stability, there is no doubt about it. A favorable biological environment is sacrosanct with a good healing at the fracture or a non-union site. We all know that chances of non-union and poor healing are high with tobacco. So we should request the patient to go for reduction in tobacco. So I think these are the problem areas. So how can we avoid the problems? We should prefer LRS for diaphyseal fragment or large metaphyseal fragments only. Stable fixation of fragments should be done. Minimal traumatic corticotomy should be the norm. Alignment of fragments has to be proper. And pin site care is very, very important. I'll just run through a few examples. I received this case while I was at Pune. This was one of my last cases when I was moving out from Pune. The individual had an open fracture of the entire femur bone associated with entire femur bone loss and comminuted tibia. What we did is we did a primary tibial nailing, and it's an open injury, so we debrided the whole thing and put a cement spacer. At that time, I was not sure of what I was going to do, but I had applied a primary alpha fixator. Subsequently, I went in and did a proximal femoral corticotomy and started distracting the whole thing. The gap was around 25.5 centimeters. And you can see the fragment getting transported. It took a long time. I didn't have the courage to apply a plate because you can see the length of the transport fragment. Finally, in around 230 days of distraction, this the whole thing got transported, and just about a month back, I have removed the LRS and tried to protect this long regenerate with the help of a long distal femoral locking plate. These are the clinical pictures and the videos of the patient. I have allowed him weight-bearing ambulation, and these are the videos of yesterday. Another case example, a non-union of the femur, wherein we applied, when we had to create a gap of around 7 centimeters and the mid shaft, and did a proximal femoral corticotomy and did a guided transport over the LRS. And here you can see the complete healing. We then removed the LRS and did a nailing also, and now the patient is doing well. These are the final walking videos of the patient. This is a case which I had done with Dr. Manish Dhawan at Gangaram Hospital. You can see infected non-union with a gap of around 5 centimeters. LRS has been applied appropriately, and the final pictures of the patient, clinical as well as radiological. And another case with sir only we had done. So these are the images. We have a publication also on around 50 plus cases of complicated segmental bone transports using LRS in lower extremity in the Journal of Limb Lengthening and Reconstruction. So with that, I would like to thank you so much. Thank you very much.
Thank you, Dr. Prasad. So, okay, question answer in the last.
Fantastic. I think that's the longest transport so far, probably in India. Well done. Congrats.
Thank you, sir. Thank you, sir.
मनीष नीचे से ही प्रेजेंट करने को बोलो ना मनीष
Good morning. I think everybody must have good breakfast and good sleep. So I'm going to talk about role of LRS, that is limb reconstruction system, or some people call it as rail system. ये कौन सा दबाने का है? Next here. ये दबाओ ना. Indications for LRS use is limb lengthening. You can do in open compound fractures, infected non-unions, severely comminuted closed fracture, juxta-articular fractures, orthodesis, and osteotomies. Ideal external fixator is stable, simple, adjustable geometry, comprehensive, lightweight, inexpensive, and easy to tackle. This is the LRS. You can see here, this is the rail, and over this, these two compartments or 3 or 4 compartments can move on this rail track. This is a oblique. If there is your pin is little oblique, you can use this one, where you can have a oblique a fixator. And this is a screw which is tapered end. Now this is less, and this is 5.5 and this is 6.5. So when you push this screw inside the bone, when it comes out of the distal cortex, you must see that it should not go too much, because if you do this nail, take it out, try to take it out, 1 or 2 screws, threads, then it becomes loose. So once you put it, you should not take it out. We have done non-infected cases about 28 and infected cases about 72. Males were 80, females were 20. In 44 cases out of 100, we have used femur in 44 cases, tibia for 52 cases, and humerus 4 cases. Indications of use of LRS in our series that orthodesis of the joint in 4 cases to achieve compression and stability at the fracture site, 54 cases, limb lengthening, 8 cases. For stabilization of fracture and bone transportation after corticotomy in cases of infected non-unions with bone loss, 34 cases. Some cases I am going to show you. This is a 13-year-old female with a compound grade 3C fractured tibia fibula with neurovascular insufficiency. After vascular repair and multiple debridements, plating was done outside. This was the plating done, and she presented with an infected gap non-union with plate exposed. Scars and sinus is present, plate exposed, sensory deficit. So what we did, we have done the thorough debridement. We have removed the plate and removed all the granulation tissue and soft tissue which was badly stuck up there. And then distal corticotomy and transportation we have done. This is the distal corticotomy here, and this portion was transported. This is the transportation completed, and LRS was removed and fracture united. Second case, this is Alam Khan. He had a fractured shaft femur with fractured patella. Now somebody did nailing for him, but without distal fixation of the screws. So what happened, gradually the telescoping occurred. This portion went inside the bone, telescoping, and did 5 centimeter shortening. You can see here the bone is telescoped inside. So we put a LRS on him and distracted the distal fragment, overriding of the fragments and shortening of 7 centimeter and non-union. So we distracted that, which took about 5 months, and LRS applied and fracture site distracted. Gradually, after distraction, the fracture united in due course of time. Union and limb length restored with help of LRS. 1 year, 2 months post-op. Distraction, osteogenesis, no bone grafting. No need of bone grafting in such cases where the distraction was done and good union achieved gradually. Third case, this is a fracture, lower 1/4 of the tibia, compound fracture with partial bone loss, operated in another hospital with intramedullary nail. Now you have fracture, it is everybody tries to do the nailing. So nail was done. But after 2 months, there was no sign of callus formation. So, as usual, somebody did dynamization. So after dynamization also, after 9 months of dynamization, the fracture did not unite. So the third surgeon did bone grafting. Even after bone grafting, the fracture did not unite because the fracture ends were sclerosed and therefore which required, so he came with a persistent non-union after 4 surgeries, despite of all measures taken by bone union by previous surgeon. So excision of avascular sclerotic ends was the answer for that. And then that was done, excision of the sclerotic ends, bone graft was done, and bone transportation was done, and the fracture united. This is the clinical picture. And proximal corticotomy we have done. Here. And union achieved in limb length restored. Knee orthodesis, this is a very good case of LRS for knee, septic arthritis of the knee, and very well your patient can walk about after fixing this LRS. For the knee orthodesis, you can give compression and orthodesis occur very fast. Another case, long-standing infected non-union used as a compression device, LRS, and the fracture united. Another case, non-union of childhood chronic osteomyelitis. This is the chronic osteomyelitis of the femur and where LRS was put and the fracture united well. Another case, infected non-union, corticotomy and bone transportation. 9 months follow-up, fracture united. Problems with LRS are sometimes pin loosening occurs, pin tract infection occurs, bending of the pins at pin bone interface. Monolateral fixator hence cannot take full weight as against the ilisaur fixator. Limited span of pin placement zone in LRS. But LRS is a highly stable, rigid, but lightweight, simple to use, comprehensive, inexpensive, easy to handle and patient friendly. See, LRS, I feel LRS is very patient friendly than the Elizaro fixator, and it has a wide range of applications. Thank you very much.
Thank you, sir, for a nice presentation. Now I invite Dr. Manish Dhawan.
Case presentation दिखा दे.
Please show the case. Yeah, please show that case.
एक भी केस प्रेजेंटेशन दो 1 मिनट का है.
Yes, sir.
नहीं ये नहीं है. केस प्रेजेंटेशन. क्या हुआ है? नहीं है क्या? हाँ? Be reported with stage reconstruction with immobilization of the limb in a plaster or external fixator and cancellous bone grafting or vascularized free tissue graft. Most patients managed with these undergoes multiple surgical procedures. Despite the results, these patients undergo a seemingly unproductive course of treatment in which the level of disability related to a long bone fracture can actually counterbalance benefits of the limb salvage. G.A. Elizaro from Kurgan in the 1960s developed osteosynthesis and technique combining mechanical and biological factors. The technique involved removal of non-viable tissue and all foreign bodies or hardware, application of a constructed wire fixator ring frame and connection by distraction, osteogenesis or compression. This is the history. I'm not going to. Infection. He said that infectious birds is the fire of the regenerate. पहला केस था ना क्या था? ये केस presentation. This is the case presentation. A 26-year-old young man got a fracture, comminuted fracture, tibia fibula, in June 14. This is is after the debridement of the an external fixator. Then cross leg flap was put on the tibia. Ilizaru transportation for 7 centimeter gap that finished in December 14. Docking completed at good regenerate 7 centimeter in September, 7 centimeter long. Regenerate was formed in September 2015. Ilizaru removed in 2016. Then the patient was walking about, but he was complaining of slight pain. So I thought that there is a non-union, so I did nailing in 2016. But with the nail also, still he was complaining of slight pain and could not walk properly. So therefore I did derotational plate at both grafting. And in 18, that is after 4 years of primary injury, the fracture united, patient is walking about very well. So this is the clinical picture. You can see that there is no difference between 2 legs. And he can walk about. Thank you very much.
Thank you, sir, for a nice presentation. I invite Dr. Manish Dhawan.
Okay, boss.
ये मेरा नहीं मेरे को दे दो Yeah, good morning everyone. See, almost most of the instrumentation and everything has been already been discussed. So there is no point repeating it. What is not there, I will speak. I'll show you one animation in real time how you apply this thing, and then I go for the case discussion. Because I'm leaving all the stuff because it has been covered by Dr. Manish Prasad and Dr. Junjunwala. So I'll leave all this. Now just see this animation, how it is done real time, and then I show you cases. So suppose there is a fracture here. So this is the fracture. The first step is when you apply, you have to give traction. Once you give traction, almost everything is, it comes into place. 80 to 90% fragments, they come into place. Then what you do, once the fracture is distracted, you put the rail there, and there are templates available. The white stuck thing is the template. Because LRS is a stiff fixator, the pins are thick, so it has to be very precise. So always use template. You put the sleeve. First thing is that you drill the topmost. Once it is done, then you drill the last one. And then you drill the other ones. The rest remaining you drill. And first important thing is that you have to put the first pin first, put the last pin, and then the assembly is fixed. Then you put the other one. So these are the other holes which we are drilling. Then you remove the template, put the clamps, the central clamp and the end clamps, and then at the last you put the CD unit. So this is the way you do it. So now I'll show you the usefulness. I'll show you multiple cases. Actually, I have a series of, in the literature, maximum number of LRS applications for bone transport, and it is in our own journal, that is LLRS, and Dr. Milind Chaudhary is a very, very tough taskmaster. It is not indexed because yesterday Milind Chaudhary told it's not indexed, but getting an article published is a nightmare, or I can say it's a Herculean task. And he is witness to that. He is very tough, very tough. So this is a case number 1, comminuted compound distal tibial fracture. And this is a 21-year-old male sustained comminuted fracture. And he had a skin damage, and LRS was applied with minimal fixation, with cannulated screw fixation at fracture site. So this was the situation. You can't do internal fixation. Just fixed cannulated screws at the fracture site and applied the LRS frame. This is the patient with the frame. This is his after removal. You see his knee movements. Case number 2, this is aseptic atrophic gap non-union femur. Excision of atrophic fragment was done and docking at non-union site and corticotomy at proximal level. This is a bifocal transport by LRS and 28 years old male. Now you see this gentleman is one of my early case. This is the first case. He stays in Nepal, and this is the picture of the X-ray, and he used to walk on a Thomas splint. He went to 3 hospitals, nobody touched him. He used to walk with a Thomas splint. So this is, picture is of 2007. So what I did that I docked it, did a proximal corticotomy, and this is the situation. He is in Nepal now. He cannot be traced. So this is his picture after the frame. His knee was stiff. So this is a polytrauma patient with compound comminuted fracture distal tibia. 1 corticotomy bone transport done for bone loss and osteomyelitis. So this is a polytrauma, multiple fractures. So this was osteomyelitic, necrotic fragment. This was excised, debrided thoroughly, and transported. This is patient with the frame. You can see the flap, LD flap. And this is his union. Sorry, the video is not working. He has a perfect thing. You can't make out that he had a transport. Now, this is a 55-year-old patient, had a grade 2 compound fracture right tibia. Debridement and plating was done. Patient developed infection, draining sinus, non-union persisted, removal of implant, debridement, excision of non-union fragment, and distal tibial corticotomy was done. So this is a situation, multiple scars. This is the whole situation, infected. So all the muck, the sequestrum, everything was removed, debrided, and we did the transport. Patient with the LRS frame, they walk perfectly, full weight bearing. You see his walk. This is after removal. You can't make out that we had done a transport and he had a osteomyelitis. So this is a 17-year-old patient, has a grade 3 compound fracture tibia, debridement and universal external fixator, and VAC application was done. And now you can see this thing. This is the whole situation. This is infected. LRS was applied. Somebody put K-wires. Everything was removed. This is whole necrotic avascular fragment. Bone transport was done. Patient walking with LRS frame. You can see his union. Patient after removal, I always put them in plaster for some time because the pinholes are very big, so it can cause fracture. See his gait in the plaster, his knee movements. This is 43-year-old patient, had a grade 2 compound fracture left tibia. Patient had an infected wound. And debridement was first done and universal fixator was applied, and then he was referred to us and LRS was applied. So this was the whole situation. Very, simple looking fracture, which can be treated by internal fixation, but he had infection, compound. This is patient with LRS frame. We debrided the area and just compressed them. Patient after removal of frame. Case number 7, 22-year-old patient had a single bone mid-shaft fracture tibia, initially treated with plaster, progressed to ununited delayed union. And what I have done, this was somebody treated with plaster, he had kind of not a proper union, he had a fracture. So what I did that I applied LRS frame, did the fibular osteotomy, and just did the chipping technique which I showed yesterday. This is a Japanese technique. You just make a small hole and chip the whole area. It works like a graft. Applied the frame, patient started walking on the frame, without support. And you see that it went into union after removal of the frame plaster. So this is the technique which I was basically telling about, and this was introduced to me by Dr. Milind Chaudhary. I got this idea from a lecture he had given long time back, went to that article, and I've done almost 12 cases with this thing, and it perfectly worked. No need for bone graft, just chip the area and stabilize it. So this is a 24-year-old patient, had a fractured distal third tibia and treated with interlocking nail, and there was no union, and locking screws had broken also, and then we applied. This is the situation. You see there is a non-union. Removed the nail and excised the non-union, did a proximal corticotomy in the femur and see the union. See his knee movements. So this is 27-year-old patient, had a gunshot injury. Actually, he was just standing outside his house, and in Northeast there was some, gunfire, some procession was going on. He was shot. This was his bullet hole, bone loss. We removed everything, debrided, applied LRS. Then we put grafts in this area, stabilize it. This is the union. See his knee movements. So this is 26-year-old patient, had a closed fracture shaft tibia, closed interlocking nail was done, had infection, and then we had removed the interlocking nails, and cystectomy was done, and LRS was applied. So this is the situation you can see, draining wound. Removed everything, did a proximal corticotomy after infection settled, transported the fragment. This is a see his knee movements. This is the union. So after removal of LRS, the video is not working. This is a 49-year-old female patient, had a closed fracture shaft humerus. Plating was done and went into non-union. Twice actually they did the plating. And then patient was referred to us. So I removed this thing. This is a 2 times plated fracture. Excised the non-union. Applied LRS. In humerus, some shortening is tolerable, so I just excised and docked this area. This is the patient with LRS frame. It went into union. You can see her movements. So this is a 36-year-old male patient, had a closed fracture shaft radius at the upper 2/3 and lower 1/3 region, and patient developed infection, had a, the plate became loose. Debridement. So this was the situation, plated, infected. So I removed everything, all debrided the whole area, applied LRS in the forearm. This was the situation. What I did that I took fibula and harvested fibula once infection settled, and used an intramedullary wire to attach fibula and applied, stabilized with LRS frame. This is in his radius LRS, the mini pediatric LRS. So this is a 24-year-old patient, had an open fracture right mid-shaft femur with skin loss. And first universal external fixator was applied, and patient was referred to us for further management. So this is his femoral fracture. All skin, flaps and split skin graft has been done. The patient went into union with LRS, patient with LRS frame. Good movement, acceptable movement, see his gait. So what I was mentioning, Dr. Manish Prasad also mentioned, so this is in JLLRR, this was published last year, and this is one of the largest series of bone transport by LRS in the literature, which I have checked it, and I think second series belongs to Rajesh Rohila. I think it's 34 cases. Thank you very much. So this is basically, oh sorry, it's gone. 1 minute. So this is from the journal, 50 patients, and all with rail fixator. So this is the findings. Thank you.
Dr. Rajiv Kaul.
So, thank you, Manish, for pointing out this. I just take a minute while Lieutenant Colonel Rajiv Kaul is going to start. Presentation is different from publication. Remember this. Presentations are easy. Nobody is going to stop you and say, Ki, why are you talking like this? But for publication, you have to be thorough. And we aimed, see, India is rising, we all know that, okay? We all are the 4th largest economy in the world, and we want to be the 3rd. One of the things we also have to improve is in our ability to publish articles with the right kind of quality. So I congratulate Dr. Manish for having gone through the process, and it's something that stays with you throughout the life, the discipline of writing a very well-constructed article. Thank you. Colonel Rajiv Kaul, please.
So, good morning, respected chairpersons and dear friends. We move on from LRS to a slightly different topic, and that's 6-axis. And I'll be briefly touching upon the Smart TSF, which is the newer version of the old Taylor special frame, and the TL hex fixator. So, greetings from the land of Uttarakhand. This is where I work. So, limb reconstruction, we know, is an evolving art from the discovery of the tension stress effect by Professor Elizarov in the 1950s to the evolution of the latest state-of-the-art hexapod systems. The first description of a hexapod device was in the form of the Goff-Stewart platform, which was used in tire construction and later in aircraft simulators. The first hexapod in orthopedics was the Elizarov hexapod system in Germany in 1995, but that was more of a mechanical system and did not entail the use of any software. So it was finally the brainchild of these two gentlemen, John Charles Taylor and his brother Harold Taylor, who are accredited for patenting the first computer-assisted hexapod device for deformity correction based on the inputs provided by the user. So basically, in 6-axis, there are some terms that you need to be familiar with. There is a fragment which is fixed and is called as the reference fragment. And there is a fragment which is mobile that is called the moving fragment. So the fixed fragment has a distalmost point called the origin, and the moving fragment has the uppermost point called the corresponding point. And basically you need to tell the software where these 2 points are in 3D space by parameters such as the AP view angulation and translation. Similarly, we have the lateral view angulation and translation. And in the axial view, you have translation and rotation. So based on these parameters that you feed the system, the computer sets up a grid which is perpendicular to your reference fragment, and hence the importance of the reference fragment. So it is important to align your rings absolutely perpendicular to the reference fragment so that you avoid these unnecessary changes in the mounting parameters. So this kind of configuration should be avoided. So how does one get this perpendicular X-ray? If you see, this is an obliquely placed ring, and the same thing, if you just by tilting the rings a bit, you get an absolute bird's eye view of the ring. How does one get that practically? So one technique described is the silhouette technique, in which the shadow of the X-ray machine is cast on the ring to produce a shadow like so. This is an example of how we use this technique. And a better technique which I feel is the use of a spirit level, which can be mounted on the proximal or the reference fragment as shown, to get this kind of ring that you desire. And then the computer can construct its grid as desired. And this has been published in Injury by Professor Hemant Sharma and his team. Next, the computer wants to know where is the ring center, the geometric center of the ring. So certain systems such as the TL hex have these ring markers, and one method described is by the intersection method. That is, one line is along the ring, and the second line is from the tip of the upper marker to the tip of the lower marker, and the intersection of these 2 lines is the center of the ring. However, my preferred method is to use two metallic devices such as hexagonal sockets, and you sort of overlap these sockets to produce a shadow of or a superimposition of these two to get the center of the ring. Now we come to the True Lock hexapod system, which is marketed by the Orthofix from Italy, and it consists of these aluminum rings with a detachable 3/8 portion like so. It has a foot ring with a radiolucent arch. It has a U-ring and an extension clamp. And these are put together like so. The struts have a ball and socket portion at the top. It has a gradual adjustment knob with a scale and a portion for fast adjustment. These two are affixed onto the ring using these hexagonal set screws. So if you notice, the struts are mounted outside the ring and they do not occupy any of the holes on the ring. Then we have some added features like the rocker rail for foot and ankle deformities. We have this dynamization unit. So if you notice, it can accommodate maybe 2 to 3 millimeters of dynamization here. I hope you can appreciate that. And it has a magnification marker. I'll quickly take you through the software. So the software wants to know where is the reference fragment, is it proximal or distal? Once that is done, it takes you to a module called the hex ray, which is basically an integration between the planning part and the X-ray that you've just taken. So the first part is the calibration, which I'll quickly script through. Next, you mark the osteotomy in both the views, in the AP and the lateral view. Once that is done, and the software will create these two trees. So you need to align these trees according to the reference fragment and the moving fragment. So you can use the mid-diaphyseal line or the joint line tool to get your alignment as desired. Like so. And you get an apex. And you can keep on adjusting till you have decided where you want your apex. Like so, I got an apex which was higher up. I wanted to move it slightly down. So you can always go back to the previous page and keep adjusting. So now the software will perform the osteotomy and it allows you to align your rings according to the X-ray shadow. So if you can see, please notice here. So it allows you to drag. So in case you haven't got that orthogonal X-ray, you can still get away with this feature. You can tilt the ring and make it exactly, superimpose the X-ray. So this is a unique feature of this software. So once that is done, the software will recreate the deformity and it will show you the simulation post-correction. And all the mounting parameters have been calculated automatically by the software. You don't have to feed them in manually. So the rest of it is pretty standard. It creates a chart and a prescription which can be handed over to the patient. So this is an example of a distal femur which we performed on a sawbone, and this is the kind of correction that you can achieve. Now we come to the Taylor spatial frame, which consists of these black aluminum rings. On the top we have the old ring, and at the bottom we have the new ring with 14 holes and the master tab. Then we have the foot ring, that's a half foot ring and a completed foot ring, and a U ring, which is used in foot and ankle to form the butt construct. Apart from that, we have the strut, and this is an old strut. It was the fast fix system, a magnification ball, and the equator clamps to mark the ring center. Now, they have stopped manufacturing the old system and they've shifted to the new hardware, which is the smart TSF hardware. Basically, the rings have been modified to accommodate not just the standard mount, but the custom mount as well. So you can position your struts this far apart on the master tab. The struts themselves have undergone modification. So instead of having 1 millimeter once a day, you can now have 0.25 millimeters of increments 4 times a day. And they also have these color-coded bands for patient friendliness. And this is the most important feature. It's called the beacon, which is basically an X-ray magnification marker, which has some metallic spheres embedded onto it. So the beacon is mounted on the reference fragment and an X-ray is taken. I need 2 minutes more, please. Based upon the position of this beacon in space, the software can calculate all the mounting parameters and the calibration automatically. So you do not need to feed in any information to the computer. Everything is picked up automatically by the software. Then we have these Z plates to avoid strut crowding. And we have some dynamization washers on the reference ring. So this is the software. I'll just show you the important features. So once you've entered your ring parameters, you can choose a custom mount or a standard mount. And based on that, the software creates this 3D impression of the ring. So if you do the rings first method, in which the frame is pre-constructed, your frame should look like this. Next, the software has its own tools, calibration tools, and so on. And then you can plan it using this method called the super dot method, which is nothing but the Cora. So the software allows you to place the Cora at the apex, and then you can rotate your moving fragment around the Cora. So basically all those things that you can do with a Bone Ninja or any other PACS software is inbuilt in this software. So you do not need any separate surgical software for planning this deformity. And then, again, this software also has this feature of tilting the rings. Notice how you can tilt the rings. So if you do not have that perpendicular X-ray, you can still get away with it. And once you finalize that, the software automatically calculates the mounting parameters. Rest of the steps are pretty standard. You have the structure at risk, and then it creates a 3D model of the deformity as well as the rings. And you can rotate that, and you can also simulate your correction. So please notice how this software is simulating the correction. You can get an idea of how your deformity would look before and after correction in all the 3 views. Right? So, in case you do not want to do it this way, you want to stick to a manual method, you can always use the old PACS system in which all the mounting parameters were calculated using a PACS, and you can feed it in manually into the software. So this is a case which I just demonstrated, an ankle equinocavovarus deformity. This was the correction, and this is what we could achieve. That's the patient. He also had a procavatum of the femur. So we corrected the femur acutely, followed by gradual correction for the foot and ankle to get him a reasonable alignment like so. So these are just some subtle differences between the software, nothing great. Only thing that the Smart TSF has some additional features for planning your osteotomy. Otherwise, the features are fairly comparable to each other. Finally, this is the future of deformity correction. This is the ortho-spin system from Israel, which consists of, it's its only kind, fully automated struts in which the patient does not have to do any sort of manipulation on his own. All the programming is done by a smart control box, which is mounted on the ring like so. And it controls the motion of these struts and sends real-time feedback to the patient as well as the surgeon. So the surgeons sitting in the US can monitor the patient in Israel using this software. Just for information, OrthoSpin has been taken over by Depu in 2011 and is now marketed as MaxFrame. This is the future. It's a completely automatic system with no need for manual adjustment. And finally, in a nutshell, hexapod systems require a meticulous pre-op, intra-op, and post-op planning. You need to be familiar with the hardware as well as the software. Under corrections are common, so no need to get perturbed. There's always a residual mode. You can always program the second program without taking the patient back to the OR. And you should monitor the weekly progress weekly because things may not go as per plan. So be ready for surprises. Thank you very much.
Thank you, Lieutenant Colonel Rajiv Kaul, for this exhaustive explanation of these newer systems. Unfortunately, they're not available in India. So, probably we'll have to make do with what we have. Thank you so much for your wonderful talk. If there are, we'll take a question or two. Manish and
Asghar Ali's. Dr. Asghar Ali's. No, he's not here. Sir, he's not here. Then, momentum, please. Yeah. Sir, I would like to call upon on the dais the following speakers to receive their memento. Sir, Milind sir, would you, Colonel Manish Prasad, please, to receive a memento. Dr. Rajiv. Thanks. Thanks. Thank you, sir. Please, one sir,